Hello and welcome. This is part 4 of our educational series for Advent Health Medical Group Fatty Liver Disease Clinic. This lecture is actually going to be going over a risk for advanced liver disease and what role fatty liver disease plays in progression of liver illness. A few things to review that we've actually talked about in prior sessions is what does the liver do? And what is the importance of having a functional liver? Well, your liver performs over 500 different functions. To name just a few of those, it's responsible for filtering and eliminating toxins such as alcohol, pollution, preservatives, chemicals from the blood that acts like a giant filter, keeping the inner workings of your body balanced and well functioning. So it truly is a filter for your blood. Your liver also breaks down fats, carbohydrates, proteins, and it helps to kind of target or keep your weight stable. So you can imagine that if and when your liver becomes dysfunctional, you may have a hard time with metabolizing or breaking down fats, carbohydrates, and proteins and stabilizing your weight. So the other things that we really kind of focus on about the liver, although these are simply just a few of its functions, is that it regulates various hormones. It stabilizes your blood sugar and your cholesterol levels. So we know that individuals who do have advanced scarring of their liver or fibrosis or cirrhosis, they may have an even more challenging time if they were already diagnosed as a diabetic or someone who has hyperlipidemia, high cholesterol, or high triglycerides, even more challenging than to control those conditions. The liver also produces bile and bilirubin, and these bile and bilirubin actually aid in the digestion and aiding in digestion and elimination. So basically, if you lose this process, you're unable to metabolize those things we had talked about before as well. So what happens then if you are diagnosed with non-alcoholic fatty liver disease, or NAFLD, or non-alcoholic steatohepatitis, or NASH? So let me just explain again. I know you've received it in prior presentations, but non-alcoholic, that makes sense. Steato, which means fatty. Hepatitis, which means inflammation of the liver. So NASH is as a result of fat accumulation around the liver that causes it to become inflamed, therefore the condition titled non-alcoholic steatohepatitis. Individuals who are diagnosed with non-alcoholic fatty liver disease risk the development of non-alcoholic steatohepatitis. What happens is that individuals over time, well, your liver, one of its functions is that it packages fat. But if you package too much fat and it stores it in excess at the site of the liver, what will happen over time is that when the fat continues to accumulate, it will cause the hepatocytes or the liver cells to become inflamed. And then you go from a diagnosis of non-alcoholic fatty liver disease, meaning just the presence of the fat around the liver, to NASH. Now you have not just the fat around the liver, but the fat has now caused the liver cells to become inflamed. So now we're dealing with inflammation of the liver in addition to the presence of fat. Individuals with non-alcoholic steatohepatitis are at a higher risk of developing other conditions, such as metabolic disorders, as we've discussed, and cardiovascular disease. We also understand as liver specialists that cardiac-related deaths are one of the leading cause of mortality for people living with NAFLD or NASH. We know that if left untreated, that NASH can progress into cirrhosis, liver cancer, liver failure, or result in death, and is expected to become the leading cause of liver transplantation. So let's talk a little bit about the progression to liver cirrhosis. And we've come up with this roadmap to kind of help you better understand the process. So inflammation in the liver leads to injury and cell damage. So let's step back one step. Non-alcoholic fatty liver disease, the presence of fat, has led to non-alcoholic steatohepatitis over time. The fat has caused the liver cells to become inflamed. This is where we're picking up. Inflammation in the liver then leads to injury and cell damage at the site of the liver. The liver can repair itself when it's been injured, which is nice. However, the process of healing involves the creation of scar tissue. So your body responds to the liver cell inflammation by lying down scar as a way to try and heal itself. But the issue is that if you continue to have the offending agent, in this case, the fat around the liver, you're unable to kind of put out that inflammation or put out the fire, if you will. So you will continue to have more inflammatory change continue to produce. And if you can imagine, it's your body's response to healing that is laying down scar tissue. You can imagine that over time, your liver becomes more and more scarred. So repeat or continuous injury to the liver can cause significant scarring in the liver, and the body can tolerate a partially scarred liver without any sort of serious consequences, but we know that eventually the scarring can become so severe that the liver is no longer able to perform its normal function. Let's take a look here just at a picture of what we're describing. So an individual has a healthy liver, if you will, on the left-hand side. And what happens over time, say, for example, you're a diabetic and you have maybe high triglycerides or high cholesterol, and both your blood sugar and your cholesterol and your triglycerides are actually very poorly controlled. So these individuals we know are highest risk for developing fat accumulation around the liver. So when you deposit the fat, initially there's really not a lot of injury to the liver. However, if the fat continues to stay there over time and your body doesn't use it as a source of energy, what will happen is you will develop the inflammatory changes at the side of the liver, and we now have NASH. So fat has led to inflammation. Your body responds to the inflammation, not the fat. Your body responds to the inflammation, and the way to try to heal it, it lays down scar tissue or fibrosis. Some of you are familiar with the term fibrosis. We tell you that in clinic, your fibrosis score is, we give you a number. So when we talk about the body laying down scar tissue to heal the inflammation, scar tissue or scarring is synonymous with fibrosis. So it's important that we understand those terms. As you understand, if the inflammation continues, as it will, if the fat isn't eliminated from the side of the liver, then what will happen is that you will eventually progress from fibrosis stage 0, which means no scarring of your liver, to fibrosis stage 1, which is kind of mild scarring, fibrosis stage 2, moderate, fibrosis stage 3, advanced, fibrosis stage 4, also known as cirrhosis. And individuals who develop cirrhosis then increase the risk of developing what we call hepatocellular carcinoma, which is a liver primary cancer. In individuals who are cirrhotic, at that juncture, you are unable then to heal your liver itself. So kind of at the side of F3 or advanced fibrosis to F4 or cirrhosis, at that point, kind of the damage is done. But if you have been assessed and you have fibrosis stage 1 or 2, certainly eliminating the causation or the fat will slow down the inflammatory change to elimination. And as a result, you will not continue to progress through the fibrosis score and your body can heal to some degree. But again, let me reiterate, if it's advanced scarring, advanced fibrosis or cirrhosis, F3 or 4, there is no turning point back to a normal healthy liver. At that point, you then may require or be evaluated for a liver transplantation, not only just the diagnosis of cirrhosis, but depending on other factors as well, which we'll explore. So what is cirrhosis and how have you developed cirrhosis for those of you who have it? So cirrhosis is a disease in which the liver becomes severely scarred, usually as a result of many years of continuous injury in the way of inflammation. The most common causes of cirrhosis are alcohol abuse, chronic viral hepatitis B or C, fatty liver disease, which is what our clinic is focused on primarily, often seen in people with obesity or poorly managed diabetes, and as I had mentioned, cholesterol. In its advanced stages, cirrhosis is usually irreversible. So treatment may involve a liver transplant if, for example, the individual becomes decompensated, which we'll go over. In its early stages, so early liver fibrosis, like I had mentioned, fibrosis stage 1 or 2, it may be reversible if the underlying cause can be treated. So let me give you an example. Say there's someone who abuses alcohol. If alcohol is the causation of the liver inflammation, the way to eliminate the inflammation of the liver is to remove the alcohol. Similarly, if someone has been infected with viral hepatitis B or C, and that is the cause of liver inflammation, The way to eliminate the liver inflammation is to treat and/or cure the viral hepatitis. Now, pulling it relevant to our clinic, we are addressing fatty liver disease. So similar to alcohol, similar to viral hepatitis, if those are the causative agents of the liver inflammation, we know inflammation is the causation of liver scarring. So in this case, fatty liver, if fatty liver is the causation of inflammation, we have to eliminate the fat from around the liver. And this can take on many forms. We can do this in the way of controlling our weight, which has been proven to actually be the most successful way to actually eliminate fat around the liver. Okay, it's really the only natural way to do it. So we understand that a 10% total body weight loss over a period of time can actually not only lead to elimination of the fat, which occurs at around 5% of total body weight loss. And at the 10% mark, we actually can have reversal of some of the fibrotic changes or scarring in the early stages, F1, F2. So we address the causative agent that causes the inflammatory reaction then to reduce or halt the progression of scarring to the liver. I briefly mentioned this. Cirrhosis is cirrhosis, but it's classified in two primary types. You can have compensated versus decompensated disease. Compensated is when you do not have any symptoms of liver failure. So they may look healthy to everyone else around them. Decompensated disease or decompensated cirrhosis is when your cirrhosis has progressed to the point that your liver is having trouble functioning and you start having symptoms of liver failure, which we'll explore. Here are some signs and symptoms of decompensated cirrhosis. Individuals can develop jaundice, which is a yellowing of the skin, or icterus, which is a yellowing of the white of the eyes. Confusion, which is driven by a condition known as hepatic encephalopathy. So liver patients become quite confused because, as you understand, the liver, one of its many functions is to eliminate toxins. And if it can't do that successfully from the blood, if it can't eliminate toxins from the blood, what happens is your blood that is not filtered properly continues to recirculate. And what happens is you develop this waste product in your blood as a result of no or poor filtration at the side of your liver. And then this kind of waste product turns into a gas known as ammonia. And when your blood circulates through your brain, the ammonia gas leads to confusion. And we call that hepatic means liver, encephalopathy. Signs of upper gastrointestinal bleeding, such as vomiting blood or having bowel movements that look like tar or that contain blood. Okay, bright red blood from the rectum, dark, tarry stools from the rectum. That's called melena. When someone has a bleed in the upper digestive tract, say the stomach, for example, your blood is then digested as it moves its way down the alimentary tract or the intestines. And as a result, when it is excreted or when you defecate or have a bowel movement, blood will look dark, black, tarry, excessively foul smelling. But if you have bright red blood, it's likely that the bleeding source is from the lower GI tract, such as the colon, for example. Individuals who have these upper GI bleeds who are cirrhotic, we understand that individuals who have cirrhosis are at a higher risk of developing engorged, dilated blood vessels inside their esophagus, their stomach, their spleen, around their spleen, sometimes at their rectum. These are called varices. So when someone's been diagnosed with cirrhosis, whether compensated or not, your GI doctor or your liver specialist will recommend that you have a baseline endoscopy, which is where they take a scope with a light and a lens at the very end. While you're asleep or sedated, the endoscopist or the physician will use this scope to actually look inside your esophagus and your stomach and the very first portion of your small intestine to identify if you have developed varices in the esophagus or the stomach. If you do have varices, your risk of bleeding actually increases. And by doing these endoscopies routinely or surveillancing you for varices will reduce your risk of having complications as a result of these varices. So varices, I should back up just a minute. When your liver is cirrhotic, it becomes shrunken and solid, and blood cannot flow through it at a normal rate. And what happens is that blood flow backs up. And when the blood flow backs up, it basically will then kind of increase the pressure of those vessels in which it's backing up in. This is called portal hypertension. And when you develop portal hypertension, okay, one of the way it manifests is the development of these varices, because these blood vessels are having to accommodate more blood as it can't move through the liver at a normal rate. The other thing that can happen is your spleen can become congested with this blood, and your spleen becomes large. We call that splenomegaly, another sign of decompensated cirrhosis. You can also develop swelling in the abdomen. This is a condition, it's caused by a condition called ascites, which is when fluid builds up around the organs in the abdomen. And then you also can develop a lower extremity edema or swelling in the lower extremities, such as your legs, your ankles, your feet. Mood changes is a very common thing that we see. Excessive fatigue or lethargy, those with abnormal sleep patterns as the circadian rhythm has become dysfunctional. We understand, as you heard earlier, that hormone kind of processing, okay, is part of the function of the liver. So absent or irregular menstrual bleeding in women who have cirrhosis is common. Erectile dysfunction or infertility or loss of sex drive or reduction of libido in men, something that is seen. We also see what's called gynecomastia, or breast bud development in men, for the same reason of the hormonal dysregulation for someone with cirrhosis. And then also something called spider veins, where you can actually look at your skin and you'll notice that there are these very superficial veins that look like spiders that will develop. There are many causes of spider veins. So please, if you do have those and you don't have cirrhosis, please understand that that is not just unique to cirrhosis. This is what I was mentioning earlier to you, a condition called portal hypertension. Now that I've kind of introduced it, I would like to help further define it. So portal hypertension is when the blood pressure inside the portal vein, which is the main source of blood for the liver, gets too high. So that main source of blood to the liver, the pressure becomes elevated. And this is as a result, this happens because scars in the liver obstruct blood flow through the actual liver itself. And as the pressure builds up, the blood backs up into nearby blood vessels, primarily in and around the esophagus and the intestines. And those are called varices: esophageal, gastric varices, like I mentioned before, rectal varices. We also notice changes in your hands. You will probably see one of the healthcare providers in our clinic asked to look at the palms of your hands, either formally or during our assessment of you. We actually are taking a peek at the palm of your hands, because we know that individuals with cirrhosis the cirrhosis can affect the hands. It causes the palms to redden, the nails to whiten, or they develop these white stripes, and the tips of the fingers often will widen. So we look at your hands, okay? Blood abnormalities are very common in individuals with decompensated cirrhosis. So people with cirrhosis often have abnormalities in their blood. So for example, they can have abnormal levels of certain proteins and enzymes, and their blood may not clot as well as it should. Plus, they don't always have enough certain blood cells to accommodate. And this is why one of the reasons we routinely do blood work on any individual who has cirrhosis. So at your initial evaluation, say for example, you have come to us either with a diagnosis of cirrhosis, or maybe there's a question of, do you have cirrhosis? So the initial evaluation, we're going to perform a physical examination. We're gonna do a lot of things on your physical exam, but one of the things that we're gonna feeling for are signs of an enlarged liver or spleen. We call this hepatosplenomegaly. This involves us using our hands to actually push on your abdomen to feel for enlargement of these organs. We also look for signs and symptoms of decompensated disease, such as what I'd mentioned: yellowing of the skin, yellowing of the whites of your eyes, spider veins. We're also going to be assessing the palms of your hands. We're going to be having you put your hands out like this, straight forward, and tell you, hold your hands out straight with your wrists back, act like you're telling someone to stop. we're going to be doing a lot of assessment when you're in clinic with us. And this all is helpful for us as clinicians to determine whether or not you might have signs or symptoms of what we know as decompensated disease. We also will routinely be scheduling you, anyone with cirrhosis, every 6 months, okay? Every 6 months for an image, okay? So we need to look at your liver every 6 months because, as I had mentioned before, that individuals with cirrhosis, whether compensated or decompensated, are at an advanced or an increased risk of developing hepatocellular carcinoma, or liver primary cancer. And the way we screen you is every 6 months, we'll perform either an ultrasound, a multiphasic CT scan, or MRI of your liver and abdomen. We also do a laboratory evaluation. In addition to every 6-month imaging, we also will perform what's called an alpha-fetoprotein, which is a tumor marker that we use to help us in our assessment of hepatocellular carcinoma screening. It is not a diagnostic test, this LEB test. It simply just gives us a gauge. It tells us a number, and then to us that can be helpful and let us know whether or not we need to perform further testing or not. In addition to the AFP, the other laboratory evaluation that we do is we look for the functionality of your liver. So the biosynthetic function, we look specifically at the albumin, your platelet count, looking at these proteins, looking at these blood components to determine whether or not you have classic signs of cirrhosis. Oftentimes, our cirrhotic patients will have a reduction in their platelet count, which is called thrombocytopenia. We'll also note that their albumin is abnormal. And we'll also note sometimes that their INR can be increased. There's a lot of things that we look at to determine the functionality of your liver, and one of those things is the biosynthetic function, or the functionality of the liver itself. The other thing that we're going to be doing is the endoscopy, which is where we do that light and lens kind of down your esophagus into your stomach while you're asleep to assess for esophageal and gastric varices. So after the initial physical examination, if you do have the diagnosis of cirrhosis, forevermore, you'll have imaging at least every 6 months. You will also have labs every 6 months at least, and then a baseline endoscopy, and then surveillance endoscopies, depending on what was found on your baseline endoscopy, but typically every couple of years or so, okay, sometimes more frequent. As part of your evaluation, initially when you come and see us, say you don't have a diagnosis of cirrhosis, well, then it's our job to actually do what we call a fibrosis staging. Okay, so hepatic fibrosis staging, and we have to get a gauge to determine whether or not you do have cirrhosis or do you not have cirrhosis. And if you don't, what stage of fibrosis might you have, if any at all? So when you first come to us, you'll likely undergo hepatic fibrosis staging. We do this in a number of ways. Anytime you come in initially, we calculate based on your lab scores that were sent to us at the time of your referral, what's called a FIB-4 score. And this is a very kind of a loose way of determining whether or not you might have scarring to your liver. Usually we will then send you for a non-invasive scan, a FibroScan, or an MR elastography. These are non-invasive, and depending on the results of those two, we may then need further exploration with a more invasive test known as a liver biopsy. Staging fibrosis is something that's essential to us because management of your fatty liver disease is strictly dependent upon whether or not you have cirrhosis or not. The risk of cirrhosis, there are many. Individuals who do develop cirrhosis have a risk of esophageal varices and variceal hemorrhaging, so maybe from the esophagus, maybe from the gastric varices or stomach varices, ascites, that fluid accumulation that I had mentioned to you in the abdomen. Sometimes you can develop what's called spontaneous bacterial peritonitis, which is when you have this infection that ensues in peritoneum, usually associated with those who develop ascites. It's very common for individuals to develop electrolyte abnormalities such as low sodium, okay, hyponatremia. Thrombocytopenia, as I mentioned, is the reduction of platelet counts. Hepatic encephalopathy is when I mentioned that waste product kind of continues to circulate throughout your blood because the liver can't filter it when it's cirrhotic. And as a result, that waste product lets off a gas known as ammonia. And when that blood travels through the brain, then that ammonia gas causes confusion. known as hepatic encephalopathy. There's a condition called hepatorenal syndrome, essentially the workload of the liver. The workload of the liver has reduced, right? It's not filtering. The only other filter within your system is the kidneys. So the kidneys are now having to work a little bit overtime, and individuals who develop cirrhosis or end-stage liver disease oftentimes can develop kidney dysfunction. Additionally, those who develop liver disease or failure or cirrhosis, these individuals can develop pulmonary conditions or lung conditions, such as pulmonary hypertension, which is when the blood the blood in the vessels within the lungs becomes too great, creating the pressure gradient too high, and you can develop pulmonary or lung conditions, which is known as hepatopulmonary syndrome. And as I'd mentioned before a number of times, individuals are at a higher risk of primary liver cancer known as hepatocellular carcinoma or HCC. To kind of recap on the screenings that I had mentioned earlier is that anyone who has cirrhosis forevermore, we're going to be doing HCC or hepatocellular carcinoma screening. So imaging with an ultrasound, multiphasic CT, or an MRI every 6 months, and the blood test known as the alpha fetoprotein every 6 months as well. We also perform variceal screening. So again, as I had mentioned, a baseline endoscopy to monitor for esophageal and gastric varices, and then pending those results, routine variceal screening endoscopies are required every 2 to 3 years, but certainly sometimes more frequently, depending on what was seen or found during your baseline endoscopy. So a lot of patients ask us, well, then what can I do to prevent further damage to my liver if I already have cirrhosis? Well, we know that one of the best things to do is try your best to keep yourself healthy. We also want to make sure that you don't contract any additional condition that may be preventable that causes inflammatory change, potentiating more scarring to your liver. For example, we recommend that our patients with cirrhosis receive hepatitis A and B vaccines, because were you to actually contract either one of these infections, then what can happen is that viral infection can cause more inflammation to the liver, which is already injured, and then lay down further scarring, worsening your liver condition. Unfortunately, there is not a vaccine for hepatitis C. That's why you don't see it here. But we do recommend cirrhotics or anyone with advanced liver scarring receive vaccines in the way of hepatitis A and B to protect against viral hepatitis. Minimize any potential toxins to the liver. So we recommend alcohol abstinence, so no alcohol. Avoid any sort of non-steroidal anti-inflammatory drugs. This would be like ibuprofen, for example, because it increases your risk of bleed. It's okay to take Tylenol and acetaminophen, but do not exceed 2 grams if you have cirrhosis in a 24-hour period. That's kind of the upper allowed amount of acetaminophen or Tylenol that you should have. Again, we do allow Tylenol in individuals with cirrhosis. I know a lot of individuals have been told, don't take Tylenol if you have cirrhosis. Well, you certainly can. You just should not exceed 2 grams in a 24-hour period. Don't take any cleanses or herbal remedies that are kind of marketed to clean the liver or heal the liver, and discuss any of these supplements with us so that we can really take a look, because you can actually cause further injury or harm with these cleanses or herbal remedies, depending on what they are, leading to a condition known as drug-induced liver injury. You should minimize certain prescription medications as the liver can't clear them well, so such as benzodiazepines. Some of those are like Xanax or Valium or Klonopin. Narcotics such as Percocet, morphine, and oxycodone. These are just a couple. We're not saying that all people with cirrhosis can't take these. We're simply saying we should minimize these. We should sometimes dose reduce them. Sometimes we should look for alternative type medications. But this is certainly something you should discuss with your liver specialist as well, were you to be on any of these medications. And it's also something that we routinely look for. And that's why it's very important that we have an up-to-date medication list. And if you don't know your medication list, we encourage you to write one down, and that you bring it to every time you go and see one of your healthcare providers. Alternatively, you can certainly bring the bottles with you if you're unsure what you're taking, so that our medical staff can make sure that your chart is up to date and we can provide you optimal care in that way. So for treatment, we have a few treatment aims for cirrhosis. The first part of treatment for cirrhosis involves identifying its underlying cause and treating that if possible. As I had mentioned, with fatty liver, we treat the fatty liver. If it's alcohol, we come off the alcohol. If it's viral hepatitis, treat the viral hepatitis. If it's autoimmune hepatitis, treat the autoimmune disease. It really depends on what's causing the cirrhosis. So for example, if a person's cirrhosis is due to alcoholism, it's imperative to stop all alcohol. Likewise, if a person's cirrhosis is caused by NASH or non-alcoholic steatohepatitis, it is important to work on weight loss and controlling contributing factors such as diabetes and cholesterol. Slow or reverse the cause of liver disease, okay, that's goal. Prevent, identify, and treat the complications of cirrhosis. Protect the liver from other sources of damage. Manage symptoms and blood abnormalities, and determine if and when a liver transplant might be considered or needed for an individual. So that is our treatment aim. Liver transplant is reserved, obviously, for individuals who have a kind of end-stage liver disease or kind of the cirrhosis, right? And typically you can have cirrhosis and still have a functional liver, okay? But these are reserved usually for individuals who have what we consider kind of this recurrent decompensated disease or decompensated cirrhosis. So a liver transplant is the definitive treatment, excuse me, it's the definitive treatment for people with advanced cirrhosis and liver failure. However, not everyone with advanced cirrhosis is a good candidate for transplant. So if you have decompensated cirrhosis and advanced cirrhosis, it doesn't automatically mean that you would qualify for a transplant. Okay, some of the reasons why people might not be good candidates include liver cancer that's spread outside the liver, significant heart or lung disease, non-liver related cancer, for example, colon cancer that may have spread to other places that has not been excised, okay, or resected rather. Patient's own liver is working too well to undergo a liver transplant. Maybe it's too early. Again, just because you're cirrhotic doesn't mean that you need a new liver, okay? Liver transplant is a complicated, major surgery. So people undergoing the surgery need to be healthy enough to survive the surgery and the recovery. Even people who are good candidates must wait for a compatible liver to be available, and this can take some time. Even if you identify a living donor where you have someone that you may know who is willing to donate a portion of their liver, the process takes time. So you don't just all of a sudden need a liver and get a liver. That's generally not how it works. That's why we manage you, we follow you closely, and we look for warning signs that your cirrhosis may be worsening, and we start to evaluate you appropriately to determine, are you a good candidate, yes or no, were you to need a liver? And then we work to get you listed and put you on our transplant, the national transplant list, or the institutional list, essentially. Other major concerns following a transplant are the risk of anti-rejection drugs used to suppress the immune system, which have potential side effects, and the risk of rejection of the transplanted organ. So your doctor will determine whether a liver transplant is appropriate for you. But just so that you understand a bit about the process, it's complex, it's major surgery. Not everyone with cirrhosis needs a transplant. And certainly if you need one, not everyone who needs one qualifies for one. So it's important not to get to this point, but say if you do have cirrhosis, it's important to preserve the functionality of your liver that does remain. These are my resources for today's presentation. I want to thank each of you for taking time to listen to our educational series that we've put together for you. We trust that this information has been educational and helpful. And certainly when you come back for your follow-up visits within our clinic, were you to have any outstanding or remaining questions, we always invite those because we really do advocate for patients who want to advocate for their own health and allowing us to partner with you to optimize your liver health. Thank you again from the fatty liver disease team here at Advent Health Medical Group. We appreciate your attention, we appreciate your questions, and we appreciate the opportunity to help aid in your healthcare. Have a wonderful day. We look forward to seeing you in the clinic. Take care.